One of the other things I wanted to say was if I say anything too technical or I go too fast, stop me and just ask me. Feel free to interrupt. And if there's any questions that you want to ask, I don't mind being interrupted. So I'm one of the gerontology consultants working here at the John Radcliffe, and it's a really wonderful opportunity for us to talk to you and tell you about the changes that we have made to try and improve care for patients with dementia coming into our hospital. So I'm going to talk briefly about the spectrum of cognitive diseases that we see in our hospital inpatients. I'm going to also talk about how we found out about the number of patients who are coming in with these problems, the importance for early identification of these patients, and strategies and ways that we are looking at of improving identifying these patients who are at risk of problems. So this is a similar slide to which has been shown before. What we see patients coming in have a wide range of cognitive issues with thinking and with memory. And again, with normal ageing, there may be a slight decline, but not too much of a decline. But we see patients all the way through, coming from the very, very mild form at the preclinical stages, where actually often the patient knows that they're not functioning at 100%, but to all intents and purposes, the clinicians and family and relatives haven't picked up on this, and things may just perhaps be a little bit slower. We then move on to the mild cognitive impairment stage, and this is when friends and relatives are picking up that perhaps people are slightly more forgetful or struggling finding the right words. And it's often at this stage that patients are starting to go to their GP and present to services and being identified as having dementia. And then we've got people who come into hospital already being diagnosed with dementia. And again, within that dementia diagnosis, there's a huge spectrum. So we have people with very mild disease who are able to function normally and continue at home, and then going right through to the end where we've got end stage, very severe disease. And in these cases, sometimes people are looked after in nursing homes and institutionalised care. One of the other problems that we commonly see in hospital is delirium. And the word delirium is derived directly from the Latin, meaning deranged or off track. It's something that we commonly see in hospital. It's very underreported and under-recognised in some settings. You often see two distinct forms, but there is an interplay between both of them. The common forms are the hypoactive delirium, where patients are very sleepy, very drowsy, and very hard to rouse and engage. And then the other form, which is much more obvious to people, where they are hyperactive. So these are patients who are very agitated, very confused, wandering around, often trying to climb out of bed or picking at bedclothes is commonly something that we see. The important thing about delirium is that it's an acute state of mental confusion, and it's acute in onset, so it comes on suddenly, and it fluctuates and varies over time. There are lots of different things that can precipitate delirium, and even if you've cured the thing that's caused the delirium, so a waterworks infection or chest infection, sometimes the delirium can persist for sometimes after the initial problem has been sorted. It's important though that we don't think of these problems with memory and thinking as single entities. There's a lot of overlap, there's a lot of interplay and a lot of interchange between them. So we know that patients who have a dementia, when they come into hospital, they are much more likely to either come in with a delirium or develop a delirium during their admission. And also patients who have a delirium who may not have been diagnosed with dementia or mild cognitive impairment previously are much more likely to go on and develop a dementia in the next years and months of their lives. And also we know that memory and thinking and cognition in hospital will fluctuate hugely throughout the course of an illness. So you will get ups and downs, and then generally over time, the level of cognition tends to decrease with repeated insults. So it's becoming increasingly more recognised as being important tackling dementia early on. Over the last couple of decades, the government have really engaged with this, and they've published the National Dementia Strategy and the National Dementia Sequence, trying to engage the public and hospitals in managing these patients better. In response to this, the Royal College of Physicians published this document, Hospitals on the Edge, A Time for Action, in 2012. And in this document, they identified that nearly 2/3 of people being admitted to hospital were over the age of 65, and there were an increasing number of frail patients coming through the front doors, and increasing number of patients with dementia. They also highlighted in this report that actually the hospital buildings, the services and the doctors were ill-equipped to be able to manage with this demand. So as a result of that, there's been a lot more emphasis on how we can improve our care. So we're faced with many challenges in hospital, but when it comes to thinking about the cognitive problems our patients see, we know it's common, but actually how common is common? We need to find out exactly what's going on. And as I said before, particularly it's often under-recognised and under-reported, and that's a problem we have particularly with delirium and the sleepy hypoactive deliriums. And actually the rate of memory problems in hospital varies hugely across the specialties and across the settings. So people coming into hospital with a planned knee operation, for example, tend to have very low rates of problems with their memory and thinking. But if you look at the patients coming in through the accident and emergency department with medical and surgical emergencies, they have very high rates of cognitive problems. So the aim of the research we decided to undertake in Oxford was to actually work out the actual numbers of people coming through the front door of the hospital with emergency admissions who had problems with their memory and thinking. We wanted to improve the recognition and identification of these patients so that we could improve their care and their outcome. We know it's important to identify patients with memory and thinking problems early because these patients tend to stay in hospital for longer and therefore accrue the problems of being in hospital for longer. So are much more likely to run into problems with hospital-acquired pneumonias, problems with decreased mobility. We know that they have a higher rate of mortality. We also know that on discharge, often patients who have memory and thinking problems need bigger packages of care in the community and often end up going to either residential homes or nursing homes. So it's important that we recognise these people early and we give them the best management that we can. It also gives us an opportunity to talk with families, patients, relatives and GPs so that we can plan for the future and make sure people are plugged into the right services going forward. And also, particularly with dementia, there are some factors which are modifiable. So if we know that you're at risk of dementia, we need to take good care of it, make sure you're not getting constipated, make sure the electrolytes in the bloods are okay, make sure you're well hydrated, good nutrition. These are all factors that we can do with people when they come into hospital, as long as we realise they are at risk. It also helps us plan the way we deliver services to the rest of the hospital. So what did we actually do? We looked at all of the medical patients coming in on the medical firm that I worked with, coming through A&E or being referred by GP. We screened them on admission to see whether they had a delirium, and we looked at them every day during their admission to see whether they went on to develop a delirium. We used national and international recognised criteria to diagnose this delirium. We also then looked to see whether they had a known diagnosis of dementia on admission through GP records and hospital records. And during their admission, we performed cognitive tests. We also collected a lot of other data looking at their functional status, markers of frailty, and where they were discharged to and what needs they had on discharge. So we had quite a lot of data to gather. At this point, we had about just over 500 patients. The work is ongoing and we are collecting more data. We're repeating it again and we're near coming up to the 800-900 mark at the moment. But the data that I have today is in 500 patients. The average age was just under 68 and it was slightly more females than males. Of that, we found that the overall number of patients who had a delirium was about 20%. But if you look, as the older you get, the more likely you are to have a delirium. So just over 1/3 of the patients aged over 75 in the Oxford Hospital coming through the front door with a medical emergency had a delirium. And you were much more likely to get it the older you got. And this graph really just represents that again. You can see the number of patients coming through much higher in the older ages, and the black bars represent those who have had a delirium. So you can see that as you get older, you're more likely to come into hospital and you are more likely to have a delirium. Thinking about dementia, we noted that just over 21% of patients over 75 years old had a previous diagnosis of dementia before they came into hospital. But actually, when we performed our memory tests on people when they were in hospital, we found it to be actually about over 50% of patients having memory problems. Now, not all of those patients with memory problems identified on this test had dementia, because there's the interplay between delirium and people being unwell in hospital and being at home in the community. However, this does raise problems that they're probably at risk and we do need to think about it, and we did try and do our final cognitive assessments on people when they're in a stable phase coming towards discharge, so not when they were too unwell to participate. So I think actually, although we are diagnosing 20% of people with dementia, it is probably higher. So just to summarise those results, looking at the patients over 75 years of age coming into the medical take at the John Radcliffe, 1/3 we found to be confused, 1/5 we knew already had a dementia, but over a half of them had some problems with thinking and memory tests. And this really does impact on the treatment and the decisions that we are making with patients and their families when they come in. And we know it's important because cognitive impairment is associated with poor outcomes. So we had those results. What did we do? We changed the way we clerked patients and we changed the way we do the admissions pro forma. This is a copy of the paper pro forma, and you can see at the top, underneath the name, the first thing that comes up is reminding the junior doctor who's clerking the patient in to assess for memory. That's the first thing they should be doing on every patient. When they come in over the age of 75, we're asking for them to fill this in so we can identify patients who are at risk. Now, we're moving away from paper and we're going to electronic patient records. So we've made a pop-up box that is going to flash up on the screen every time the doctor opens a record for somebody who's an inpatient over the age of 75. And this will keep coming up until they fill it in. So they have to fill this in. The difficult thing with that, though, is the score that we use to identify delirium is the CAM score, the Confusion Assessment Method, and it's a well-recognised score and is very valuable. The only problem is, the first question it asks you is this acute in onset and does it fluctuate over time? Now, at 2 o'clock in the morning, when I'm in the emergency department and the patient's in front of me without a relative or a carer, how do I know if this is acute and how do I know if it's changing? And while continuity of care is really, really important and looking after the same person, that is very difficult with service demands and provision that we have now. So this score is useful, but not ideal to identify people as early as they come through. So we decided to have a more pragmatic view and see whether we could develop a different type of score. So we went back to the NICE guidelines, the National Institute for Clinical Excellence guidelines of delirium, and looked at some of the factors that they pulled out and they said was important with patients with delirium. We took some of those factors and developed our own score, which we've called the NICE score, and we've published this data in Age and Ageing last year. And this score looks at important factors which we know for delirium. So age, cognitive impairment, severe illness, infection, and vision impairment. And the doctor clerking somebody at 2 o'clock in the morning in A&E should be able to identify all these factors quite easily without asking or phoning a relative or phoning a care home. And we validated this score and compared it to other risk scores for delirium. And we found that actually it's very reliable, it's very sensitive, and it's as good as existing scores, and in some cases better than existing scores. We know that if you score more than 5, you've got a 75% chance of having a delirium. So it should hopefully prompt the doctor to go, this patient's at risk of delirium, do they have it? Yes or no? And even if they don't have it, we need to think about this because they may well develop it, and what can we do to improve their care whilst they're in hospital. So we're continuing to develop this score. So as I said, we're moving away from paper to electronic patient records. And hopefully by the end of the year, when we are using electronic patient records, we're hoping that our score will work in the background of that, so that the doctor will be typing in all their admission criteria when they come in, and then hopefully at the end of that, it will flash up and say, we've already calculated your score, this patient is at risk of delirium or not, and therefore help us to improve their care. As I mentioned before, we're still collecting data, and hopefully we're near the 800, 900 patient mark now. And we're also looking at reviewing the long-term outcomes of patients who have been identified as having delirium, the rates of readmission, mortality rates. We're working on that at the moment. We're also developing a score, the NICE score, an app, so that other doctors in other hospitals can have it on their mobile phones, be able to type in this, and then it should flash up and say your patient is or not at risk of delirium. So that's some of the work that we've been doing. I hope you found some of that interesting. I'll be around to answer questions later if there's anything else, but I would like just to say thank you very much to everybody who's participated in this. Obviously, it's been a huge amount of work, and there have been a lot of people who've been